Hello, and thank you for joining me to discuss the prevention of diaper dermatitis in infants affected by neonatal abstinence syndrome. My name is Amy Higgins, and this presentation is a part of Nursing 830, Evidence-Based Practice 1, Research and Inquiry Methods through Pennsylvania State University World Campus. I chose this topic as I am a neonatal intensive care unit nurse who takes care of babies who have the diagnosis of neonatal abstinence syndrome, or NAS. I have seen firsthand the diaper dermatitis these infants experience, often with open bleeding areas. I have observed a lack of consistency of prevention and treatment of diaper dermatitis in this high-risk group, as there is no prescribed regimen. Nurses have their favorite products that may or may not be the best ones for the level of diaper dermatitis the infant is experiencing. Once that nurse's shift is over, an entirely different product may be used by the next nurse. This leads to a lack of consistency and parental frustration when different products are being constantly used and no improvement in their child's diaper rash is seen. I wanted to investigate how this can be improved and if having a standardized regimen would lead to an improvement in care. This leads me to the PICO question that I developed. In infants affected by neonatal abstinence syndrome, does having a skincare protocol compared to usual care without a skincare protocol decrease rates of diaper dermatitis during their hospital stay? The search process proved to be more difficult than expected. I began with the databases CINAHL and PubMed, as these are the two databases I have the most experience with and seem to be the most appropriate for my PICO question due to the fact that it is largely nursing based. I chose the key terms and limiters based on my PICO question. For limiters, I chose to initially limit my search to articles that were 7 years old at the most, with an age range of infants birth to 1 month, as well as infants 1 to 23 months. I limited the language to English only and used the subject headings of neonatal abstinence syndrome, skin care, infant care, perennial dermatitis, and hospitalization. As I began searching with the key terms and limiters I identified, I quickly realized that there was a lack of resources that included all of my key terms. In fact, when using all of my key terms with N connecting them along with my limiters, there were 0 results. Searching for my population, infants with NAS, and either my intervention, a skincare protocol, or my outcome, decreased incidence of diaper dermatitis, yielded the most results at 8. However, many of the results were not specific enough for my topic. It took more refining in my search terms to find the most appropriate pieces of evidence that related to my topic. After finding a few appropriate resources, I increased the date range to find articles that were up to 15 years old. This increased the number of results and allowed me to find additional articles related to my topic. Infants with NAS have an increased incidence and severity of diaper dermatitis for a few reasons. One of the symptoms of NAS is loose, watery stools, which can increase the risk of diaper dermatitis. Also, these babies often have frequent stools, which results in increased rubbing and friction to remove during diaper changes. Caregivers will often delay diaper changes to avoid frequently disturbing the infant as a non-pharmacologic way to manage NAS symptoms, which increases the time the skin is in contact with the soiled diaper. In this graph, you can see that in this study by Malik and others, the incidence of diaper dermatitis was 86% among infants with NAS, compared to just 28% of infants without the diagnosis of NAS. Per Glashan, the incidence of diaper dermatitis is 3 times higher in the presence of loose stools. Another aspect of NAS that is important to note is the Finnegan neonatal abstinence scoring tool, which is used to evaluate withdrawal symptoms in a drug-exposed infant. There are multiple categories the infant is scored on, many that relate to this topic. The most obviously related is the presence of loose stools. However, another category may also be affected. This category is the amount of time they are asleep, which if an infant is uncomfortable or even in pain related to diaper dermatitis, they may not be able to sleep as expected. This may increase the score and lead to an initiation of pharmacological intervention or an increase in the dosing of morphine, which is the most common drug used in the treatment of NAS. The research that I found most helpful in answering my PICO question was Glashan's, which was the only one that focused on infants with NAS. Glashan found that a lack of consistency in the skincare interventions being used, as well as a lack of a standardized tool to identify diaper dermatitis. This led to the implementation of the scoring system for Diaper Dermatitis Scale, or SSDDS, as a tool to identify diaper dermatitis, as well as a bundle of interventions focused on prevention of diaper dermatitis in NAS infants. This bundle included daily bathing with a pH-neutral soap to rinse off any urine or feces left on the skin, using superabsorbent diapers, using alcohol-free wipes, applying a thick layer of petroleum jelly with each diaper change, as well as a zinc oxide barrier cream if erythema was present, as well as a goal of 8 or more diaper changes per day. One-on-one education of the nurses was done, as well as appointing a diaper dermatitis champion who was available to answer questions about the interventions and provide guidance on using the SSDDS. After implementing this bundle, the overall rate of diaper dermatitis decreased from 64% of infants to 12.5%. Glashin concluded that consistent use of evidence-based interventions within a skincare protocol can result in a significant decrease in the rates of diaper dermatitis in infants with NAS. It was also identified that the intervention that made the most difference in the prevention of diaper dermatitis was consistent use of petroleum jelly, with a 283% increase from pre to post intervention. This evidence shows that having a protocol in place increases consistency and can decrease the rate of diaper dermatitis in infants with NAS. Another study that researched the effect of a standardized diaper care regimen included NICU infants greater than or equal to 30 weeks gestation, however, was not specific to infants with NAS. This study implemented perennial skincare guidelines, which assigned a plan of treatment for each infant. The plan started with Plan A, which was for prevention of diaper dermatitis, up to Plan D, which is for infants who had fungal lesions present. Each plan includes a picture, as well as a description of the skin assessment to assist nurses in selecting the correct plan for the patient. The plan also provided a treatment and instructions for applying the treatment products. Not only was there a reduction in the incidence of diaper dermatitis from 45.5% to 38%, a 16% reduction in incidence, there was also an increase in prevention measures. Another interesting finding was the 89.6% reduction in ordering diaper care emollients outside of the guidelines, which demonstrates buy-in to the guidelines from staff. In this study, also set in a NICU, but not specifically with infants with NAS, concerns similar to those identified in other studies were lack of consistency in diaper regimens, increased incidence of diaper dermatitis, and a lack of standardized guidelines for diaper dermatitis care. This led to the development of an algorithm that begins upon admission to the NICU. The first step of the algorithm focuses on prevention using petrolatum, daily bathing of diapered areas, and a barrier wipe. Once erythema is present, the nurse is to continue along the algorithm, which provides specific instructions as to products to use and how long to continue with each step. The authors report that implementation of the algorithm has decreased diaper dermatitis severity, however, does not provide statistics. In Highmall and others' research, the trigger for development of a standardized algorithm was nurse and clinician requests for products that were not carried by the hospital, as well as frequent diaper changes from shift to shift of the treatment plan for each infant, which does not give products time to work. After a literature review to investigate the best practices for diaper dermatitis prevention, an algorithm was designed to standardize treatment. The algorithm has both pictures and descriptions of different levels of diaper dermatitis, with goals of treatment and a standardized treatment regimen for each level, along with application instructions. The products used were divided into first, second, and third line products, with the first line product, petrolatum, available on each unit's supply card for ease of access. The second line product, Desitin, is available in the Pyxis on the units. The third line products can be ordered from materials distribution for each individual patient as needed. This encourages the use of the first and second line products and only using the third line product when absolutely necessary. The implementation of this standardization decreased the incidence of diaper dermatitis on high-risk units from 24% to 11% in a 2-year period, with the incidence of level 4 diaper dermatitis, or the most severe level, decreasing to 0% within 9 months of implementation. One added benefit to this standardization was monetary. Changing the second line product to Desitin and putting it in the Pyxis was not only evidence-based, but also saved the hospital $8,000 per year. An interesting study was one done in a pediatric oncology unit. Although my PICO question was about infants with NAS, this study piqued my interest due to similarities with the two patient populations. Infants with NAS and infants undergoing treatment for cancer both have an increased risk of diaper dermatitis due to their disease process and/or the treatments they receive causing diarrhea. This study was done due to nurses noticing that there was no standardized process for prevention of diaper dermatitis, which is leading to high rates of diaper rash. Nurses also felt the need for a guideline that was evidence-based and focused on prevention rather than treatment once diaper rash was present. Once the algorithm was developed, focus groups were held for nurse feedback, which was positive, and demonstrated a perceived decrease in diaper dermatitis as well as satisfaction with the prevention aspect of the algorithm. There was a clear theme throughout the literature on consistency being key to prevention and treatment of diaper dermatitis. Many studies even cited inconsistent care as a primary reason behind the research. Consistency was mentioned as important in not only following the regimen, but also in documentation. Esser, in 2016, stated, quote, Consistency of prevention and treatment regimens was found to be an important factor in the reduction of diaper dermatitis, along with the creation of a consistent guide for practice. End quote. Accurate documentation of the level of diaper dermatitis allows for earlier detection of diaper dermatitis. It can guide preventative strategies, gauge treatment response, and prevent worsening of the condition. Including pictures and a description of the appearance of the perineal area can guide the nurse in selecting the correct level of diaper dermatitis and following the regimen associated with it. As for consistently following the algorithm and using the recommended regimen, using products consistently gives the products time to work, and switching products before a minimum of 3 days is discouraged. Another common theme throughout the literature was a focus on prevention versus treatment. Many algorithms start prior to the first sign of erythema with a goal of preventing diaper dermatitis. These measures begin at admission to the NICU and continue through discharge, unless there is presence of diaper dermatitis and the prevention turns to treatment. In one study, nurses were asked about the new algorithm that had been put in place and stated that not only were they seeing less diaper dermatitis, the families were responding to the prevention measure and ensuring the preventive cream was used with each diaper change. Common themes with the algorithms discussed throughout the literature was the ease of their use and accessibility. Guidelines were distributed throughout the unit in several cases, which made them more visible, and nurses did not need to look up a guideline every time it was needed. Ensuring the availability of products was also key, as a guideline cannot be followed if the necessary products are not available. Many guidelines included pictures as well as descriptions to help nurses accurately assess the level of diaper dermatitis and follow the correct treatment plan. Instructions for applying the products was included in the guidelines to ensure consistency from nurse to nurse. I would like to now revisit my PICO question. In infants affected by neonatal abstinence syndrome, does having a skincare protocol, compared to usual care without a skincare protocol, decrease the rate of diaper dermatitis during the hospital stay? After reviewing the literature, I believe this is an area where more research is needed. I was only able to find one study specifically with infants with NAS. Standardization of perineal care has been demonstrated to decrease rates of diaper dermatitis in the general population of hospitalized infants. However, the evidence for infants with NAS, a high-risk group, is lacking. Infants with NAS have differing needs that may affect the feasibility of some interventions. Further, in order to find enough resources for this project, I had to increase the date range for my searches up to 15 years old, which indicates that this topic is in need of more up-to-date research. My recommendations are that there is ample evidence for implementation of a skincare regimen for all infants in a NICU for prevention of diaper dermatitis, as the evidence shows that having a regimen is effective at decreasing the incidence of diaper dermatitis. As for infants with NAS, more research is needed to address this high-risk population and their unique needs. Thank you so much for joining me.